Welcome to AETCM, the emergency medicine channel. Today's our topic of discussion renal colic or urolithiasis from the chapter of genitourinary emergency. So this is what we are going to talk today. Definition of urolithiasis, what are the types and then causes, various risk factors and then clinical features. Diagnosis part mainly we are focusing both in hospital and then pre-hospital. Management part finally complications. So coming into definition for the kidney stone or urolithiasis or urine calculi means what is that? It is a hard solid mass of material that forms in the kidney from the substance of urine. Means the three portions are there. Kidney stone in the sense that is a solid mass of material. Where it will be present means wherever in that your urinary system, that might be in a kidney or ureter or urinary bladder, or it may be in a urethra also. From where the substance is forming means it is forming, or the mass or the stone is forming from the substance of urine. Okay, so the substance of urine is a key factor in that urine stone. So we have to know what are the substance that present in the urine. First, we'll see urine normally 94 to 95 percentage it is full of water. Okay, the remaining 4 to 6 percentage, that is 5 to 6 percentage, it is about other substance like substances. So this is what we mentioned here, substance of urine. So what are the substance we have in urine? We are dividing our two portions. First is a organic substance, second is a inorganic substance. Okay, organic substance means that is organic substance that will produced from your organ system. So the things like a urea, creatinine, uric acid, so those are things comes under the organic substance. Coming into inorganic substance, that is your sodium, potassium, calcium, magnesium, and then phosphorus, some other secretion like hormones. So those are things comes under the inorganic substance. So coming into how we can relate with this kidney stone means, so we told from the substance of urine the stone is forming. How it is forming? So I think in gastrointestinal emergency, while discussing on your cholithiasis, gallbladder stone, we discussed the same thing. So the what are the substance in the bile, how it is forming the stone. So the same concept only we are applying. So urolithiasis, whenever the substance means whenever the solute level is getting higher than the solvent, automatically the stone will form. That is called the supersaturation. Supersaturation means whenever your solute level is higher than the solvent level. So if it is confusing means, solute means nothing but your organic and then inorganic substance. Okay, organic and then inorganic substance. Solvent means that is indicating your fluid or water level. Okay, so I think it will be easy. So organic and then inorganic substances higher than the fluid level means automatically it will form a precipitation or it will form some crystals, that is called the urinary stone. If it is forming in the urinary system means that is a kidney stone. If it is forming somewhere else means like your biliary tract means that is a cholithiasis, so the cholithiasis, so that is a different concept. Remember, solute level is higher than the solvent, that is called the supersaturation. Okay, so this is what this story behind the kidney stone or urolithiasis. As like we told, the stone can be in wherever, might be in a kidney or ureter, urinary bladder or urethra. So here that types of renal stone, that is majority of the thing is a calcium related one, that is calcium oxalate or calcium phosphate. And then uric acid also one of the thing, cystine less than 1%. So calcium oxalate, calcium phosphate, that will comes under the inorganic things. Uric acid uric acid and the cystine, that will comes under the organic things. Uric acid, when it will come means whenever the uric acid level is getting higher in our body, then automatically that your solvent level will decrease compared with your solute, automatically it will form a crystal or precipitation. Cystine, when it will come means cystine in a condition, so cystine we will get from the, so if higher amount of protein or amino acid excreted through our urine means at the time the cystine stone will form, but it is less than 1%, it is a rare condition. Coming into next part, that is a struvite urinary stone. This is also known as a infectious stones. Means when it will form means if the person is having or getting a recurrent urinary tract infection, or if the person is frequently we are catheterizing, or recurrently the person get into the procedure of urinary catheterization, means then the person have a risk, or the person will get a struvite urinary stone or infectious stone. One more thing is that is a triple phosphate stone. So if you are doing that urinary routine examination, there you can find the triple phosphate level. So if the triple phosphate level is getting higher, means automatically it leads to the your things kidney stones. So this is what the morphology or how the stone will be. So calcium stone, how it will be, uric acid stone, struvite stone, and then cystine stone. So causes for the renal stone, primary hyperparathyroidism. So we know parathyroidism, it is a gland that will regulate, it will regulate metabolism and then level of calcium in our body. So mainly it will act on the calcium, magnesium, phosphorus, but majorly it will take a role on the calcium metabolism and then calcium regulation in our body. So whenever it is getting into hyperparathyroidism, automatically it will revert more amount of calcium into our body. It leads to the crystal formation or urine stone formation. Distal renal tubular acidosis, it is also one of the condition. In this condition, the kidney unable to excrete the acid from the body. In this condition, the kidney will lose the ability to excrete the acid from the body. If the acid level is still retaining, means automatically it leads to the uric acid level increase, and then finally it leads to the crystal formation. So idiopathic alcohol and then dehydration, the same thing only. So dehydration also, the water level will go down compared with your other substance. So automatically it leads to the precipitation. Malignancy also one of the cause. And then other risk factors, like the person is taking low fluid, and then person who have a previous history of nephrolithiasis, and then some family history. So then uric acid level is less than pH of urine pH of less than 5.5, also one of the risk factor for this. And then assessment point, mainly in the case of renal colic, the person will present with this pain only. So pain is the first crucial factor. Second, because of that urinary stone, if the person getting into UTI, means the fever also alongside coexisting symptom we will get. So that renal colic is a form of sudden flank pain. It is a typically originate over the costovertebral angle, and then it can extend anteriorly, inferiorly toward the groin or testicle. So yesterday itself we told where is the flank and then where is the costovertebral angle. So it is often caused by the acute obstruction of urinary tract. The radiation of the pain towards the umbilicus, onset of the pain will be sudden, and then duration of the pain will be variable. Nature of the pain, it is a dull and then aching pain. Intensity wise, severe intensity will be there, and then course wise, constant pain. So in nature of pain, sometimes it can arise like a colicky pain. Colicky means whenever the stone is obstructing your outflow pathway, the pain will, the intensity of the pain will arise. So if the stone get larger from that, so it is if it is obstructing, means on the time, while the time of obstruction only, the person will have a more amount of pain. So if if the stone relieve from the area, means that relieving of the symptom will occur. So that is called the colicky pain. Okay. So and then relieving and then exacerbating factors, like person try to change his position in the bed or walking, but usually fails to relieve the pain. Usually it will reduced by the analgesic or antispasmodics. Associated that pain will associated with sometime hematuria, urinary frequency, and then dysuria, and finally fever. So this is what the area of costovertebral angle and then flank region. If it is the person in hospital, means these are the investigation we will do for CBC, CRP, electrolyte values, and then parathyroid hormone level, urine routine examination, and then we will check the any hematuria is there or not, proteinuria is there or not, X-ray abdomen to detect some stones, that is a like a radio opaque stones. So we can in that X-ray or in our X-ray we can see that stones. So that's why I told it is like a something, some stones they will absorb the radiation, and that is called the radioactive stones. something we can't see in the radiology, straight away we have to go with some other testings. So USG scan also we can do, non-contrast CT also we can do, intravenous urogram, and then other tests like uric acid, calcium, phosphate level, and then urine output also we can check. Management wise, scene size up, so the same thing only here. Mainly our focus to manage are, we have to give the comfortable position for the person, so it is not depend on us, because we don't know which position the person is comfort. We have to ask the person, in the might be sometime he feels comfort in a supine position, might be some after some time he feels left lateral or right lateral position is a comfortable position. That's why we have to give a full freedom to the person, so whichever the comfortable position the person can lie down. And then the first one is a positioning, second one is we have to manage the pain. That is the second thing. Pain, how we can manage, we can go with some based on that means severity of the pain, we have to treat according to the WHO, that grading scale, pain grading scale. Already a lot of time we discussed those sort of things. And then antiemetics, if it is pain induced emesis is there, means that also we have to manage. Okay, this is the goal for the pre-hospital. Pain management, first positioning, pain management, third one is antiemetic if necessary. So how we are treating in hospital, if the stone is greater than 5 millimeter or and less than 10 millimeter means, so straight away we are considering tamsulosin. So tamsulosin is one of the drug, it is nothing but the action wise, it have a action of antagonist of alpha and beta receptor. Okay, antagonist of alpha and beta receptor. Mainly it will act on the alpha receptors. Okay, alpha receptor we know. So if it is blocking alpha receptor means the structures, the smooth structure will relax. So main function of alpha receptor is it will constrict that smooth structures like vasculature, and then your ureter, it will constrict. So if it is blocking alpha receptor means automatically the ureter will relax, so that won't be any constriction will persist. So that is why, so if the stone is there means automatically it will drain out from that particular area. That is why action of alpha receptor, tamsulosin. So it will be like a 0.4 mg once per day until the stone passage occur, or we can continue up to 30 days. Nifedipine, calcium channel blocker also, it is a less common we are using. Increased, we have to ask the person to take more amount of fluid, that is 2 to 3 liter, greater than 2 to 3 liters per day. And then we have to manage the hypercalcemia, hyperuricemia, and then we have to hypercalcemia, it is mainly in pre-hospital we won't bother about these other things because we won't get the calcium level. But in hospital how we are managing means, just give an idea, hypercalcemia will divide into 3 categories: mild, moderate, and then severe. Mild category means, so we know the normal level of calcium level, it is somewhat around 8 to 10.2 or 10 you can remember. So if the mild hypercalcemia means, how it will be means, the level will be 10.2 to 12. Okay, moderate in the sense that will be 12 to 14, and then severe cases means more than 14 level. Okay, more than 40 milliequivalents or mg per deciliter. So this is the value. So if it is the person comes under the category of mild hypercalcemia means, majority of the cases there is no need of any special intervention like a medical treatment needed. Here you have to try to avoid some calcium food, and then we have to avoid, if whenever we are, if the person in taking any diuretic for some other condition means, here you should have an idea, you have to prevent drugs like calcium retention diuretics. Okay, like thiazides. Okay, thiazides you have to avoid, like hydrochlorothiazide, chlorothiazides, because it will return more calcium into the body. This thiazides you have to avoid. If the person comes into the category of moderate means, moderate also same treatment only, we have to administer we have to rehydrate the person thoroughly, and then mean the same time you can, if it is indicated, you can think about some diuretics like a Lasix. Okay, and then severe cases, in severe cases only, if the level is more 14 greater than 14, and then the person have a symptoms like arrhythmias, kidney stone is there, and then some other symptom is there means, then we have to interfere with an, first thing you have to give we have to rehydrate the person. or you have to give a aggressive fluids. Why we are administering aggressive fluid means the aggressive fluids through IV you have to administer. Why we are administering means, so it will have a flushing effect. So it will flush out throughout your vasculature, and then mean the same time it will flush out your kidney. Okay, that flushing action we will have in the aggressive fluid administration. That is the first treatment. We have to rehydrate, or we have to give the aggressive fluid management. So while giving in fluids, again you have to check that both cardiac and then renal system function also. That is also one of the important thing. Second thing, we have one more important thing, that is a calcitonin infusion we can give. Third treatment, that is your diuretics. So diuretics you can use your Lasix. Okay, Lasix or furosemide is a ideal choice for the this one. So you always you have to remember the thiazide should be avoided. So this is the management of hypercalcemia, mild, moderate and then severe. Hyperuricemia, how we are managing means, so we have a drugs like allopurinol and then febucostat. So this also I can explain, but as of now in a later part we will discuss very detailedly how the allopurinol acts and or febucostat how it is acting. The treatment approach for the persistent stone depend upon the size, consistency and then location of the stone. So finally, some more therapies also we have, like extracorporeal lithotripsy and then cystoscopy with the stent placement. So we will do the endoscopy and then we will place some stent. That way we can drain out, or we can do some extracorporeal. So we will some electrical waves from the outside the body. It will break down your stones and then it automatically it will excrete through your urine. So complication wise, decrease or loss of kidney function. Sometimes the scarring can occur, kidney damage, obstruction of the ureter, stone recurrence, UTI also it can lead to renal failure, urethral strictures and then infection sepsis, urine extravasation, perinephric abscess also can arise, and then finally xanthogranulomatous pyelonephritis. So these are the some common complications that can arise in the your renal calculate. So do your best. Shalom.